Welcome to the Healthy, Wealthy, and Smart podcast. Each week, we interview the best and brightest in physical therapy, wellness, and entrepreneurship. We give you cutting-edge information you need to live your best life, healthy, wealthy, and smart. The information in this podcast is for entertainment purposes only and should not be used as personalized medical advice. And now, here's your host, Dr. Karen Litzy.
Hey everybody, welcome back to the podcast. I am your host, Karen Litzy, and I am so excited to have back on the podcast today Dr. Tim Gabbett. For those of you who are not familiar with Tim and his work, he has 20 years experience working as an applied sports scientist with athletes and coaches from a wide range of sports. He holds a PhD in Human Physiology and has completed a second PhD in Applied Science of Professional Football, with special reference to physical demands, injury prevention, and skill acquisition. He's worked with elite international athletes over several Commonwealth Games and Olympic Games. He continues to work as a sports science and coaching consultant for several high-performance teams around the world. He has published over 200 peer-reviewed articles and has presented at over 200 national and international conferences. He is committed to performing world-leading research that can be applied in the real world to benefit high-performance coaches and athletes. And I would also add to that it benefits almost all people, not just the high-performance coaches and athletes. And in today's episode, we are diving deeper into his latest paper, Debunking the Myths About Training Load, Injury, and Performance, Empirical Evidence, Hot Topics, and Recommendations for Practitioners, that was just released on October 26, 2018 by the British Journal of Sports Medicine. So a huge thanks to Tim for coming on and allowing us to dive a little bit deeper into some of the myths that are in this paper. We talk about the acute to chronic workload ratio, ways to quantify those training loads, the 10% rule, and is it foolproof, and practical ways for practitioners to translate research into the clinic, because we all don't work with high-performance teams. We all don't have all of these great resources at our fingertips. So it's important for the clinician that's not working with the professional sports team to be able to utilize Tim's research. And I can tell you, as a physical therapist who goes into people's homes, I utilize this for all of my patients, whether it be the 10-year-old that I'm seeing up to the 91-year-old that I'm seeing. So a big thanks to Tim for coming on and sharing a little bit more about this paper and diving a little bit into the why of the paper. So everyone, enjoy today's podcast. Hey, Tim, welcome back to the podcast. I'm honored to have you on again.
Thank you for having me back, Karen. It's good to be back talking to you again.
Yeah, and today we are talking about a new paper that just came out in the British Journal of Sports Medicine. One of your papers, I should say, just to clarify for the audience. We're not talking about someone else's paper. And your paper is Debunking the Myths About Training Load, Injury, and Performance, Empirical Evidence, Hot Topics, and Recommendations for Practitioners. So my first question is, what's the why behind this paper?
Yeah, that's a good question to start with, Karen. Look, I think with training load, there is a lot of myths that are out there, and social media is great for sharing information, but sometimes those myths get perpetuated on social media, and they grow, and they grow into a life of their own. So what I thought I'd do is try and take some of the things that I've seen over the last few years around training load, injury, and performance, and then address some of those and call out the myths that I've seen over the last few years. Of course, they're not all the myths that are around relating to training load, but I've decided to address 5 of them.
Right. And so what we'll do is I'm just going to read through those 5 myths. And then just for the listeners, Tim and I will expand on a couple of them, but not all of them, because you have to go and read the paper. So myth number 1 was load explains all injuries. Myth number 2 is the 10% rule. Myth number 3, avoid spikes and troughs at all costs. Myth number 4 is 1.5 is the magic acute to chronic workload ratio. And sorry, that was myth number 4. And myth number 5 is it's all about the ratio. So before we even go any further, Tim, for the listeners who may not be familiar with your work and familiar with what the acute to chronic workload ratio is, can you define that for us?
Yeah, sure. Look, training load can be broken down into positive and negatives. When we look at short-term training load, we call that acute load, and that could be, say, anything from one session up to 1 week. And typically, acute load looks at the fatigue associated with training. Now, on the other hand, we have the positive effect, which is the fitness effect that comes with training. It's the training that is performed over a longer period of time, and we call that chronic load. When we take the ratio of acute load to chronic load, or the size of your fatigue relative to the fitness that you've developed, that gives us a ratio of, and we call it the acute to chronic workload ratio. When we have rapid increases in acute load, or when that ratio is really high, what we have seen is that the risk of injury also increases. So that's a sort of a bit of a snapshot of what the acute chronic workload ratio is.
Perfect. And now let's dive into one of the myths here, and we're going to stick with that sort of acute to chronic workload ratio and that magic number of 1.5. So why is this a myth?
Well, the first thing to keep in mind is that when we keep our acute to chronic workloads roughly equal, when we have small increases, small decreases in load, our risk of injury is quite low. But when we rapidly increase acute loads over our chronic load, that's when we increase the risk of injury. And what we've seen is, on average, that risk increases at around a ratio of 1.5. So when you've done 1.5 times the load that you've been prepared for, that's when the risk of injury increases. Now, when we put out the original paper, the training injury prevention paradox paper, we had there was a colourful graph in there that had a sweet spot highlighted in green and a danger zone highlighted in red or pink. Now, that graph flies around the internet, and if I should have known that if all I had to do to get my figures and papers noticed was to add a bit of colour, I would have done it years ago. But the problem is, what it appears is that when you hit a magic number of 1.5 in that acute chronic ratio, that you're definitely going to get injured, and that you can't go over a ratio of 1.5. But the reality is, things like that happen all the time. They happen in sport, they happen in industry, just in the workplace. Sometimes you're required to do extra activity, extra work that you're not prepared for. Some athletes break down, but not all athletes break down. So it's important to keep in mind that even though the risk has increased at a ratio of 1.5, it doesn't necessarily mean that you're definitely going to break. There's an increased risk, but that doesn't mean that there's definitely going to be an increased rate. So risk doesn't equal rate. And there's a lot of factors that can explain that, but that's one of the important myths to keep in mind, is that sometimes you can plan to go over a ratio of 1.5. Sometimes it's unplanned and it's unavoidable. But just because you do go over a ratio of 1.5 doesn't mean that you're definitely going to break.
And I would also think that you can also look at it, if you're under that ratio of 1.5, you're never going to get injured. Do
Absolutely.
you see that flip side of it as well, right?
Absolutely. So if you look at the sweet spot curve, and you look at the danger zone and the sweet spot, you can see that each one of those dots represents an athlete. So some athletes can theoretically be in the danger zone, but their risk of injury is really low. And then there's others who are theoretically in the sweet spot, but their risk of injury is really high. So what we're talking about there is robust and fragile athletes. On average, this is what the majority of people will do. But of course, we don't work in averages the majority of the time. We work with individual athletes. So we still need to keep in mind that some athletes will handle greater loads and can handle rapid changes in load, and then other athletes can handle much smaller absolute loads and much smaller changes in load.
Exactly. And I would also think that even if you have this more robust athlete, there are other moderating variables because you're dealing, like you said, with the person in front of you, not a dot on a chart and not an average. And something that I appreciated about this paper is sort of taking into account the sort of looking through a biopsychosocial lens. So when you're prescribing your training load as the practitioners, we also have to take into consideration, like you wrote, core biomechanics, stress, anxiety, inadequate sleep, and personality traits of this person are all going to make a difference on this 1.5 ratio.
Yeah, you're absolutely right, Karen. Look, I think this is a really key point that when we're working with athletes, when we're working with patients, yes, we want to use some scientific information. We can use numbers to help inform our decision making, but we don't coach the number. We coach the athlete. We coach the patient. That's the person we're working with, and it'd be really convenient if load explained all injuries, but the reality is load is just part of the puzzle. And as soon as we load someone, we also need to consider, well, how did they respond to that load? So we're talking about factors that can influence the tolerance to load. So we're talking about psychological factors. It could be stress. It could be anxiety. It could be things as simple as sleep quality. Mm-hmm. So all of these things will impact on an athlete's ability to tolerate load. And you also talked about moderating factors. One of the key things that separate our robust from our fragile athletes, the ones that can handle load versus the ones that break down at lower loads, there's a number of moderating factors. So physical qualities, strength and aerobic fitness, we know are important, but we also know training history, injury history, and also age. Those that are really young and really old don't tend to handle spikes in load very well. So we don't just consider one variable of the acute chronic ratio or one number of 1.5. There's a number of moderating factors that we need to consider. But importantly, it's getting to know your athlete as well, what they can handle on an individual basis. That's the really important thing, I think, that we need to keep in mind with all of this research.
Yeah, and I think from a practitioner standpoint, it's also checking in with your athlete when you see them every day, because we may have an agenda in our mind, but that patient comes in and says, man, I only slept like 3 hours last night, or I just flew in from XYZ and you're in a different time zone and I didn't sleep well. So you need to be flexible enough to be able to change your agenda for that day, I think, based on, like you said, the simple variable of sleep.
Absolutely. Anyone can write a program up on a whiteboard and say, do this. But the trick here is actually reading some body language, having a discussion with your athlete, and the more you observe those things, I actually feel sometimes those things that the athlete tell us, and those body language cues, and those little conversations and things that you read from the athlete actually tell us more than some of the numbers sometimes that we can measure. I often tell a story about, when we had no resources to monitor athletes, how could I use, what information could I use to train the athlete well? And the trick was, I had to go back. How did I used to do it? I had to go back and I had to learn my athlete. I had to work out what made that athlete tick. And I had to really get to know them when they were feeling up and they could train well, and the things that used to bring them down. Sometimes you have to work through that, but then other times you have to work with the athlete to go, okay, well, maybe you need a little bit more rest. It's definitely not a one size fits all.
No, definitely not. And I think that takes us well into the next myth I want to dive into, and that's the 10% rule. Like you said, anybody can write a program up on a whiteboard and say, okay, so each week we're going to increase 10%, or each training session increase by 10%. So can you tell us a little bit more about why that might be a myth?
Look, the 10% rule is something that's been used for a long time, particularly in endurance sport populations, and it's generally seen as a good guide to safely progress weekly training loads. Don't exceed increases in training load by more than 10%, and it's generally seen as a good guide. But it's important to keep in mind that 10% for one person is going to be completely different from another person. And I'll use a couple of analogies here. Let's consider load in terms of the floor and the ceiling. So the floor is where you have your low. It could be a low level of chronic load. And when you're at the floor, you can obviously the only way is up. So you can progress very quickly. But if you limit your weekly increases to 10% or less, then it will take you a long time to get from the floor to the ceiling. So it may be that when you're at the floor, you can progress a little quicker than 10% per week. If you're at the ceiling, if you're an elite athlete, then your chronic loads are quite high. You can't put 10% on top of already high chronic loads. It could be that you can only increase by 1% or 0.5% per week. So it's very, very much contextual. You need to take into context the chronic load and the training history of your athlete. Now, there's another extreme there, and that is what happens if you've been in bed rest for a year. So you're not at the floor, you're actually in the basement. Your chronic load is so low that just getting out of bed is a massive increase in load. So in that situation, you probably need to keep those weekly increases in load quite low, because you just can't handle 10%. So when you're in the basement or when you're in the ceiling, keep the percentage changes in load from week to week quite small. But if you have moderate to high chronic loads, then you can probably progress a little quicker.
Yeah, that makes perfect sense to me. And again, it all comes down to looking at the person in front of you and being smart about how you're going to prescribe their program.
Yeah, look, I agree. It's I think that's probably the thing that we need to keep in mind as practitioners, whether we're physical therapists, whether we're strength and conditioning coaches, is all of us have our own training and our own degrees and our own certifications that give us a certain amount of intelligence, but we still need to be socially aware. Just read some cues, read the person in front of you, have a conversation with that person. They'll tell you, if you ask the right questions, you'll lead them to the answer, and they'll tell you how they're feeling. They'll tell you where their problems are. But you just have to listen. You have to ask the right questions. You have to listen. Communicate with your athletes. Communicate with your patients.
Yeah, and I think taking a good history, if you're seeing this person for the first time, taking a good history, and like you said, using motivational interviewing and really kind of allowing the athlete or the patient to lead you to exactly what they need, because it's usually what happens. But you have to make sure that you're present and that you are, like you said, listening.
Yeah. Look, I think we keep coming back to it that the numbers are important, but we don't coach numbers. We work with people, and it might seem surprising to the scientists out there or the people with scientific minds, but a lot of our patients and a lot of our athletes aren't as excited about the scientific numbers as we are. it might seem really surprising, but a lot of them are more interested in, well, just tell me how I can get better, or help me get better, or help me get back to full function. That's their focus.
Yeah, I think if you're looking from the athlete or the patient standpoint, the main question in their mind is, what is this going to do for me? That's it. What you're going to do for me? And I think as a practitioner, we have to be able to answer that question in a way that the patient is going to be satisfied with. So if someone came to you, Tim, and said, and you've got this whole plan worked out for them, and the patient asks you, well, what is this going to do for me? What would your response be?
Well, yeah, that's a good question. I mean, like from my point of view, if let's use the example of pushing harder with chronic loads. So we want to try and build chronic loads, maybe through a shock block, for example, or in some sort of intensified training. Most athletes look at that kind of training, and there's a I wouldn't say fear, but there's kind of an uncertainty. Can I handle it? And is it actually worth it? So one of the selling points is, yes, you have to explain to them, you're going to be tired, you're going to be sore, there's going to be fatigue that you're experiencing, and you're going to go to a place that you've probably never been to before. But at the end of that, we're going to unload you, and you're going to bounce back from that, and you'll get, your physical qualities will actually reach a new level. There'll be supercompensation that occurs, and there'll be a lot of benefits physically for you. But there's no easy way to get to that point. You actually have to go through a little bit of hard work and a little bit of discomfort in order to get that benefit. And the same thing would go if we were would apply if we were talking about a patient who's coming back from injury, and we want to load early. There will be some discomfort in loading that patient early, and there may be a little bit of pain within that early loading period. But the benefits of early loading far outweigh putting them in a boot, for example, for a month and doing nothing. So part of it is kind of selling the dream, if you like, of things could be a lot better for you than what they are now. Now, we don't have to use a lot of science to do that, but because they don't necessarily want to know the science, but we have to be able to sell the dream that doing it a certain way may come with a little bit of short-term pain. When I say pain, it could be discomfort, or this is unusual, or an unusual approach for me. But the long-term benefits far outweigh that short-term pain.
Yeah, and I think that's a great way to approach that with your athletes and with your patients. So thanks for that. Now let's go on we'll kind of dive into one more myth here, and that is it's all about the ratio. So again, we're back to numbers, right? So why is this a myth that it's all about the ratio?
Okay, well, let's use an example of an athlete who's in rehab, and so their chronic load has tracked down. In theory, we could have their acute and chronic workloads could be roughly equal. So in theory, their acute chronic ratio could be in the sweet spot. And if they're in the sweet spot, then everything's fine. Their injury risk is low in theory. But what we need to keep in mind is we need to interpret that acute chronic ratio in relation to chronic load. And if their chronic workload is in the basement, if they're in rehab and their chronic load is tracked down, even though their acute chronic ratio is in the sweet spot, their chronic load does not allow them to be prepared for anything. If they're in the basement, they're a long way away from the ceiling. They're a long way away from the demands of competition. So whenever we're looking at the ratio, we also need to interpret that data in relation to chronic load, at least chronic load, probably other variables as well. But always look at chronic load and say, well, what are the demands of competition? How far are we away from being able to perform those demands? So that's one of the important things about it not being all about the ratio. And you've also mentioned previously that there's moderating factors, and there's also a whole heap of biopsychosocial factors that play a role in interpreting whether an athlete or a patient is ready to tolerate more load.
I think through all of this discussion, we're talking about acute load and chronic load. And can you give some examples of how, what measurements are we taking to get this? Because we've been talking about numbers, right? So you have that 1.5 or that sweet spot. What are some examples of measurements that we might be taking that are measuring load?
There's a number of measures that we can take of load. So if we were an elite team, we can assume that we've got a lot of resources at our disposal to do that. So we might be able to measure GPS, or if we're in an elite cycling team, maybe we've got power outputs for our bikes. But let's assume that we're in the clinic and we don't have all the resources at our disposal.
Yeah.
Then we have to build our program from the ground up. We have to monitor with minimal resources. And the way that we can do that is we can look at, when we discuss load, there's three main variables that we need to discuss. We need to talk about frequency of training. We need to talk about the volume of the individual sessions. And we can talk about the intensity of those sessions. So if you just wanted to monitor frequency, the number of sessions that your patient or athlete performs in a week, that's a type of load. But of course, it doesn't tell us about how long or how intense those sessions are. So we can build it a little further. We can go, well, let's not just talk about frequency. Let's talk about the duration or the volume of those sessions. How long were they? And then the third part is, well, you can have long sessions that are really easy, or you can have long sessions that are really hard. So what is the intensity of those sessions? And we can quantify intensity just through asking the athlete, how hard was your session today? And we can use RPE scales for that. If you have frequency, you have volume or a duration measure, and you have intensity, then you've got load. You've got a type of load that you can quantify even when you don't have a lot of resources at your disposal.
Got it. And I think that's important because the majority of people are not working with elite athletes. For us regular folks who are working out of the clinic or working in the home, being able to track frequency, length of sessions, and intensity certainly makes it a lot easier. Now, if you're tracking all of this frequency, volume, and intensity, how do you put that all together to get that ratio, to get that number?
Okay, so if we were to build a let's say a weekly schedule, for example, and that would give us acute load for 1 week. Let's say we do one session a week. One session a day for the week. So that's 7 sessions. There's our frequency measure. But we can also quantify the volume, so the duration of that session. And if we quantify the intensity using an RPE scale, just a 1 to 10 scale, then we can quantify load for each session within that week. Let's say, for example, we have a 60-minute session on Monday, and the athlete rated it hard. Now, hard on the RPE scale is a 5. So all we do then is multiply the duration by the intensity to give us load. So it'll be 60 minutes times a score of 5 will give us 300 load units for that particular session. Now, if you do 2 sessions in a day, then you can add up the daily load. Or if you do multiple sessions in a week, you can add up all of those loads across the week, and that will give you a load score, an acute load for that week. As you string more weeks together, then you can see whether your load is increasing or decreasing. And then it's just a matter of calculating your chronic load, your load over a longer period of time, and then taking the acute over the chronic to give you your acute chronic workload ratio. It's really as simple as that as a starting point.
Perfect. Thank you so much for just expanding on the math there. And again, like we said, that's the math part, then you got the person part, and that's what makes this all so hard. So like I said, we're not going to go into all the myths because we want you to read the paper, but what's next for practitioners then?
Yeah, look, I think this is the $1 million question is whenever we put research out, and I really encourage practitioners to read as much as they can, and then as soon as they read the paper, the question they should be asking is how is this going to change my practice? How is this going to change the way I train my patients or change the way I train my athletes? From a practitioner point of view, I think this paper will kind of contextualize some of the challenges that we have around loading patients. If I was to recommend one take home for practitioners from this particular paper is build chronic load. At the moment, we have a method that can safely, where we can use to safely progress and regress loads, and that comes with the acute chronic workload ratio. But the ratio itself is not the endpoint. We still have to build to something. And if we know what we're building towards, if we have an endpoint, which is our ceiling, our chronic load ceiling, then we're building towards something. So the take-home point for me with your patients, loading is key. Loading is one of those big rocks that if we can get it right, we get our athletes or our patients out of rehab and we keep them there. We keep them out of rehab and we keep them performing. And that's what we all want. We want to build robustness in our athletes. We want to build an unbreakable athlete. That's whether we're a physical therapist, whether we're a strength and conditioning coach. And the way we do that is through building chronic load. So while we use the acute chronic ratio to safely progress and regress loads, let's not forget the denominator in the equation. Let's not forget that we've got to consider chronic load. We've got to build towards something.
And do you suggest for practitioners, if they have their athlete or their patient coming in, of thinking, well, what is the end goal? What does this person or athlete want to get back to? And then work backwards from that in order to build up the chronic load?
Yeah, it's a good question. The way I do it is you want to know what is the ceiling. So what is the end point? Then you also want to know what is the floor. So what is the starting point? And you can do that through your assessments with your clinical assessments. You get a gauge of what they're capable of. And then your third piece of information that you need is what's the time that I've got to get them from the floor to the ceiling. Once you have those three pieces of information, then you can develop a program to safely build that athlete back to the ceiling. And an example I would use is if you have someone who needs to be able to, you want them to be able to get to 30 or 50 standing calf raises and they can only do 12, then your chronic load ceiling is the 30 to 50 standing calf raises. The floor is the 12. And then you need to build the time. What is the time that I have in order to get them back from the floor of 12 up to the ceiling of 50? And you can use the acute chronic ratio to safely progress that, so that you can either you can keep your time short, you can make it a really short time frame, but what that means is that you've rapidly increased load and increased risk. Or you can use really small increases and take forever to get them there. And then by the time they get to the chronic load that you need them to, they're at retiring age. So you need to be sensible about your loading as well. But the acute chronic ratio allows you to use it as a bit of a guide to safely progress to higher loads.
Perfect. Great example. Thank you so much. And I feel like you already kind of gave the key takeaway, which is building chronic load, and that chronic load is key. Is there anything else that maybe we didn't hit upon that you really want to impress onto the listeners?
Oh, look, I just appreciate the chance to talk about this stuff and get the message out, Karen. So, I think that probably from a research and empirical evidence point of view, I'd really encourage the readers to read the evidence. Use social media as a signpost, and then but that's not actually the evidence. The social media post the evidence.
What? You mean 240 character tweets, not the evidence?
Is there that many? 240 characters?
I think.
Has it gone up?
Yeah, it's gone up. Yeah.
Yeah. Well, look, I know you might be surprised at that, but I've only worked it out just recently that you actually have to go and read the paper because you actually get a little bit more information in the paper. It's a really good signpost, though. I probably didn't appreciate how important referenced blogs are because they take that paper, which is written in a really sciencey jargon, and it's pretty hard to get through for the majority of people, and it writes it in a much more user-friendly way and a lot more digestible way. And I probably didn't appreciate how important podcasts like yours are for getting good scientific information out. And it's just so important for so many people that if you can't get the scientific information in, you just can't digest big papers, then the podcasts just make it a lot more user-friendly. And it's, what you find is that the majority of researchers will speak a lot differently from the way that they write. And there's a little bit more of a story that they can tell in a podcast that they can't tell in a scientific paper. So, I think the social media and the scientific publications go hand in hand. Mm-hmm. But if you can get and read the papers, try and embed yourself in those papers, the more you practice it, the easier it becomes to digest that information.
Yeah, for sure. And I think that's great advice for everyone listening, that a podcast and a blog and Twitter and Instagram and Facebook are great for giving you synopsis, and they're great at I think, planting the seed in your mind to say, this is really interesting. I now I need to go and read this paper. So great advice. And now before we end, I just have one question left that I ask everyone. And that's, knowing where you are now in your career and in your life, what advice would you give to yourself as a new grad? Or maybe after you got your first PhD? I don't know. What advice would you give yourself then based on where you are now?
Oh, gee, you asked me this question last time, and it was a tough one then, and I don't know what I said, but this is what I think now. I feel like I've worked really, really hard, and to move my way through my career, and that's probably one of the things that defines me. Really is being disciplined and persistent and working hard. But if I had one piece of advice to my younger self is just don't worry so much, don't stress, just enjoy the ride. And I think that's probably the one thing that I look back at now, and I think I tend to land on my feet. And if you work hard enough in the important areas of your life, and you commit to something, and you are prepared to put the time in, then you don't really have to worry about things that may never happen. And you land on your feet when things go wrong, and you will get some knockbacks in your life, but you have to trust in yourself that you're resilient enough to pick yourself back up off the canvas and keep punching on and keep moving forward. And I think that's it's a good lesson for anyone that goes through whatever their career, be it an athletic career or a professional discipline, is you're going to get knockbacks in your life. But just keep working hard at it, and the harder you work, the easier things get. Don't worry so much, because everything works out in the end. So that's kind of my long little advice to my younger self. And I don't know, if someone can take something out of that, then that's great.
That's great. Thank you so much for that advice. And of course, Pete, you're on social media, so people can find you on Twitter. Where?
My Twitter handle is @TimGabbett. And pretty much any of the research I'll put on Twitter as a little signpost. You'll see it on Facebook and Instagram. But as I say, there's a signpost. Go back and read the paper if you can.
Exactly. And mention your website, please.
Yes, it's gabbettperformance.com. It'll have all the details of all our Train Smarter and Harder workshops. And keep an eye out in the US, because we're coming in January. There will be some new announcements soon. Hopefully, something in New York.
Yes.
And there's one in Santa Barbara on the West Coast. So
ooh, that's nice.
Yeah, it'd be great to meet some new physical therapists and strength and conditioning coaches at these courses.
Awesome. And of course, has to be like a siren going past my apartment as I'm talking here. So hopefully people can't hear that. But once again, the paper is in the British Journal of Sports Medicine. It's called Debunking the Myths About Training Load Injury Prevention and Performance, Empirical Evidence, Hot Topics, and Recommendations for Practitioners. So Tim, once again, thank you for coming on.
Thank you for having me, Karen. It's always great talking to you.
Thanks. Great talking to you as well. And everyone else listening, thank you so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.
Thank you for listening, and please subscribe to the podcast at podcast.healthywealthysmart.com. And don't forget to follow us on social media.